At MCTA Eric here. Today we're going to be discussing another mobilization with movement or Mulligan concept technique that is used for headaches and dizziness. It's the C1 SNAG. SNAG stands for Sustained Natural Apophyseal Glide. It's an acronym. But this is guided more toward the C1 transverse process of one side. We classically use this for an attempted correction of a positional fault or a change in C1 based on the flexion rotation test that has been well documented in the literature, both linked to headaches as well as suboccipital pain for a patient, and potentially even TMD conditions. So once you've done the flexion rotation test, which the patient would be in supine, you flex them all the way up and then establish a rotation side to side, and you're looking for a distinctive change in more motion in one rotation than the other. In this case for Megan, we've diagnosed a right C1 potential dysfunction where there is a rotation in the right transverse process. It may be sitting more toward the right side than the left. So we're going to put our thumb behind the mastoid process. We're going to slide down just inferior to that. My thumb contact is going to be on the pad, or I can get more of a distinct contact if I roll my thumb back so the pad would be facing either directly superior or at a slight off angle from that. So I call it the Bullwinkle. So once I find the mastoid and I slide that down, I can rotate my thumb back. It looks like she has some antlers on the side there. I take my other thumb and I push directly forward in that straight plane with this contact. That's going to allow for contact onto that transverse process of C1. Then what's going to happen is Megan's going to look to the left, okay, and I'm going to follow that pressure around. With this dysfunction, come on back, that C1 on the right is going to be lagging behind, and I'm going to keep pressure on that with my thumb to correct that with her active motion, making it a mobilization with movement. So I push forward, Megan slowly turns to the left, and we monitor her symptoms by communication. How are you feeling? How much pain is there? And we go as far as we can. She can give overpressure with her right hand at her zygomatic arch and give her further motion, and then come back slowly. Okay? If you're worried about communication with the patient or you have questions about that, you can always put a mirror in front and watch her facial expression as she's doing the MWM. Oftentimes associated with headache or neck pain here is just contact pressure in this area. You're going to be close to a bony prominence as well as the overlying tissues that might be sore. So we can use a motion guidance contact pad here, which is a silicone-based pad that's stretchy as well as grippy, and I can turn that over and create a double-sided cushioning for that contact that I'm going to create with my thumb. And then after I'm done, these are hygienic and I can go wash these with soap and water and they're ready for the next person to be nice and clean. So I can put this down first, create that glide with my thumb, and have her look slowly to the left. And we talk about her symptoms while we're doing that. We go as far as we can, and then she gives overpressure at the end ranges and come back. On the first day, we're just going to do 2 repetitions, and then we would recheck the flexion rotation test and determine what's happened from there and make good clinical decisions on what to do next. Thank you. Hopefully this adds some clarification to some of the techniques that we discussed today. I hope to see you next time and on future techniques and videos.